Saiful Adli is an associate professor at the International Islamic University Malaysia. He holds a PhD in audiology from the University of Canterbury, New Zealand, and a master's degree in clinical audiology from the University of Melbourne. His research interest is in diagnostic audiology with focus on auditory, speech perception, and vestibular assessment. Dr. Saiful Adli is currently the visiting senior audiologist at the Sultan Ahmad Shah Medical Center and serves as the Deputy Dean of Academic and Internationalization at the Kuliah of Allied Health Sciences, IIUM. So without further ado, I pass the session to Dr. Saiful. Olives.
Thank you very much, Mr. Saravanan, and thank you, Jensen, for organizing this program for 3 years. Wonderful to see many of you joining us today. Hopefully, we get to go through all of the sessions in this program, inshallah ta'ala. So, Assalamualaikum warahmatullahi wabarakatuh, and good evening to everyone. I'll try and make it informal and easy today, so feel free to stop me and ask questions at any time if you like, if things get confusing at any point. Let me share my screen and we'll start straight away. Okay, today's talk is going to focus more towards speech testing in noise, actually. So I am going to share with you 2 scenarios, which is quite common, in fact, at least from my experience as an audiologist. And hopefully we can try and unpack these 2 cases and see how we can enhance our clinical service by looking into testing speech perception in noise. So I'd like to introduce you to Ali. Ali is a 23-year-old dental student, year 3 dental student, who has no previous history of ear problems. He is now keen into listening, his personal listening device, and he's been using it for around 2 to 5 hours per day at around 70 to 90% volume using his earbuds. And he occasionally sleeps with his PLDs. He also complains of ringing in both ears. So, but his chief complaint is that he has difficulty listening in noise, and he finds it difficult to understand lectures and finds the lecturer's voice unclear, especially when it's a little bit noisy or when the sound system in the room is a bit poor. So he goes to see the audiologist, Mr. Saravanan. Mr. Saravanan has conducted a few tests on Ali and found that his hearing is normal bilaterally. And he has, Mr. Saravanan also identified that Ali has non-bothersome tinnitus. He performed a speech perception test in quiet on Ali and found that the speech recognition threshold is consistent with the PTA. So, and he also found no significant rollover observed, so no suspicion of retrocochlear pathology. So let's try to unpack this case first. This is quite common actually in government hospitals, where you see, you can expect to see around 10% of patients coming in with normal hearing but complaints of problems listening in noise. And typically they do have some history of noise exposure or other history that you really need to draw out from them well in order for you to get the right information. But let's try and look at the pure tone audiogram first. As we know, pure tone audiogram is a very important tool in our test battery. It will give us information about type, degree, and configuration of hearing loss. It has been used as one of the only ancillary tests to arrive to a diagnosis for vestibular disorders. So it is an invaluable tool for us as audiologists. What we need to appreciate now is that the PTA while it is important to get information about the type of hearing loss, the level of hearing loss, PTA is mostly collecting information about the sensitivity of hearing. So when we want to evaluate the hearing system, the auditory system, we want to actually evaluate the whole system. So the PTA will mostly address the peripheral hearing. However, we know that the hearing, the auditory system is much more complicated than that, and there is a need to evaluate the central auditory nervous system as well. So these are some reports from literature. You can see in this particular paper that it's quite common to see reports of auditory symptoms from people with normal audiograms in audiology clinics. This includes and not limited to issues in listening to competing noise, problem to detect source of sound, issues understanding speech sounds, especially from unfamiliar people. And you can refer to this paper for more details. Let's try to unpack this a bit more. Let's look at some histological study of the cochlea. Data from histological studies will question the degree of which histological damage to the hair cells correlate with pure tones. Therefore, in many animal studies, we found that normal hearing is evident in animals with considerable loss of hair cells. A few studies has described better correlation with pure tone thresholds and hair cells integrity at the basal turn of the cochlea, but not so much at the apex. They've interpreted the overall results as reflecting that the insensitivity of pure tone audiogram to cochlear histology. To cut the story short, then basically we're seeing that the pure tone audiometry findings does not correlate well with how healthy are the cells in the cochlea. Then there's the issue of tinnitus. We've seen many patients with tinnitus and many of them have normal hearing. A number of studies have shown that patients with tinnitus present with subtle audiological deficits observed on the audiogram. Subtle auditory deficits could be both from peripheral or central mechanisms due to noise exposure. And this could be observed using tests like acoustic emissions, testing sound localization, and also temporal processing. And despite having normal hearing, people with tinnitus are often seen to show poorer performance as compared to control group with tinnitus in speech in noise testing. In our own study done at IIUM, you can see that there are two data here. One is looking into a group of patients. There are groups of patients with tinnitus, one with normal hearing and one with mild sensory neural hearing loss. And we found that the differences in speech perception in noise between the two groups, despite having different hearing levels, are about the same. But when we looked into the handicap levels of their tinnitus using the Tinnitus Handicap Index questionnaire, we found that the performance of patients who complain of moderate to severe tinnitus is worse when tested in speech in noise. We also know that cases like vestibular schwannoma report 5 to 11% with normal hearing, and many investigate when there is asymmetrical hearing loss, despite reports of unilateral tinnitus or difficulties in listening in speech and noise. And there are other pathologies that are either peripheral or central in nature, which would have normal hearing. For example, auditory neuropathy spectrum disorder, where up to 50% of the auditory nerve atrophy secondary to hair cells damage, would show damage without any shift in pure tone thresholds. You can have normal PTAs in patients with people with multiple sclerosis, cases of age-related hearing loss, central auditory processing disorders, and all these things have varying levels of pure tone oimetry results. And what would be relevant to our case Ali here would possibly be hidden hearing loss, which is an auditory disorder. In hidden hearing loss, noise exposure result in damage beyond the cochlea without affecting pure tone audiogram. A significant development in our understanding in speech in noise difficulties came when there's a publication about cochlear synopathy, which showed that animal exposed to single dose or high dose episodes sustain damage in the inner hair cells, and therefore leads to difficulty in auditory processing. And at the moment, there are issues about how we are going to diagnose hidden hearing loss, but most literature would refer to or define hidden hearing loss as people with normal hearing but having poor speech perception thresholds in noise. Therefore, you do need speech testing material in noise in order to arrive to this diagnosis. All right, trying to sum up the first case here. After looking into the evidence that we have, there could be multiple factors that Ali could suffer from. So most typically, we need to supplement our testing with either auditory evoked potentials, otoacoustic emissions, reflexes. But core to all of these disorders would be to perform speech tests, particularly performing speech tests in noise. So having this information would help you to navigate the cases clearer. If, say, for example, the history suggests a hidden hearing loss case, and you want to probably investigate the case further, then you can try and proceed with auditory evoked potentials to see whether you can pinpoint the area of the disorder. And therefore, once you know what is the cause of the hearing difficulty, then it will probably be easier for you to manage this case afterwards. Moving forward, next case is Encik Ahmad. Encik Ahmad is a 72-year-old retired teacher from Sabah. Due to family concerns, he reluctantly accepted that he needs hearing aids. He felt that the hearing aids, eventually he felt that the hearing aids didn't help much, especially in noisy places, and found them uncomfortable. So Encik Ahmad seek help from Mr. Saravanan, and Mr. Saravanan has diagnosed Encik Ahmad with sloping mild to severe sensory neural hearing loss, has proceeded with a hearing aid trial and fitted Encik Ahmad with hearing aids, and also performed aided pure tone thresholds and found that his articulation index score was 0.82. For those who have forgotten what articulation index is, it's just another tool to try and describe how much access to the speech banana, if you want to call that, access to speech sounds, which is a tool that is commonly used by audiologists to see whether aided or amplified hearing has allowed this patient to hear enough sound or not. The fitting session went smoothly, but however, by the next appointment, the vibe that Encik Ahmad was giving is slightly different. So despite having supposedly good prognosis with very good articulation index score, meaning very good aided access to speech sounds, you want to call it that, Encik Ahmad is still not happy with his hearing aids, and he can't hear speech clearly and demands Mr. Saravanan to do something with his newly bought hearing aids. So there's quite a lot to unpack with Encik Ahmad. It is a bit more complex in terms of how we are going to manage Encik Ahmad here. First of all, we need to establish that when we fit hearing aids, typically we do it in a quiet room, and when patients go back, the actual sound that patients hear is actually a lot noisier than what it is in our clinics, as you can see in this slide here. This is a collection of few studies over many years to show you that the signal to noise ratio in everyday life is different and could be very challenging, especially in areas that we know are a bit noisy, such as public transportation, in parties or in gatherings, and so on and so forth. So therefore, the impression that you got from clinic can be misleading if you depend on the reports purely based on your clinical observation. But what I am more concerned here is that many audiologists depends on aided responses when you want to verify amplification. While this has very good face validity, especially to show patients the benefit when using hearing aids before and after, patients can see, oh, they are hearing a lot better with when we show the aided audiogram, that the access to sounds seems to be a lot better. But we have to understand also that the hearing aid nowadays process sound differently and respond differently at different input levels. A simple understanding that gain is used to prescribe, when gain is prescribed to patients, we don't want patient to hear all sounds until 0 dB. This is totally unnecessary, especially when we acknowledge that patients with sensory neural hearing loss can have abnormal loudness recruitment and hyperacusis. So there needs to be a more complex or more efficient way for us to verify patients' hearing in a more realistic way. I am going to move quickly from hearing aids to cochlear implant to show you what I'm talking about, because this is a study that we've done. Here, I want to show you that in patients with cochlear implants, when tested with speech perception in quiet, most of patients with cochlear implants are able to pick up sounds or speech sounds very well. More than half, more than 70% of the patients show that the speech perception of more than 80% at comfortable levels in quiet. However, the situation is slightly different when we look at their performance in noise. So what you see here is the relationship. First, I'm going to show you the relationship between aided thresholds and speech test performance in quiet using the Bahasa Melayu speech audiometry test, and then the aided performance between compared to the Malay digit triplet test, which is a test in noise, and the Malay metric sentence test, which is also a test in noise. And we found no correlation between aided threshold performance and all of the speech tests that we've done on our subjects. We found also no correlation between speech tests in quiet and in noise, which suggests that the processes involved when listening in quiet and listening in noise are two different processes, and this test has to be performed separately to get more information about your clients. The other thing that we should ask is that why not just listen to what the patient says? And this is something that we often do in clinics. We ask the patient, they're happy with the quality of sound or not, whether they are able to hear voices clear or not, based on subjective reports. So we've also done a study to see whether the positive effects reported by patients when they use the satisfaction in daily listening questionnaire, and we derived the positive effects of using the device and compared the results to the speech audiometry performance in quiet and in noise, and we found no correlation between the perceived positive effects of using their device, and also the speech test. Meaning, most patients will have a very skewed understanding of what good or positive performance is like with their devices, but true objective tests should be able to give you a better understanding of how the patient comprehends speech in different listening situations. All right, those are the two cases that I would like to share for now. The idea here is to see that without the speech in noise test, there are a lot of questions that we are unable to answer. So to be able to serve your patient better, to understand the case better, it is very important that we have and establish a speech speech test in your clinic, and more importantly, having a variety of speech tests, which includes speech tests in quiet and also speech tests in noise. Moving on, how do we measure? How is speech understanding measured in noise? There are two main ways for you to evaluate speech understanding in noise. One is by using SNR 50, which is the 50% point. It is also known as the speech reception threshold in noise. And the threshold of the speech, the signal to noise ratio needed to, it is defined as threshold at which the signal to noise ratio needed to understand 50% of the signal use, and the signal can be a variety of things. The other way to use speech test in noise is to categorize the results in different brackets called signal to noise ratio loss. This is in reference to the results that you've obtained from a group of normal hearing individuals, and then based on those results you start to put different levels and brackets to identify the severity of the person's ability to perceive speech in noise. This would help you to be able to compare the performance of that patient with a normal hearing group and see how far away the person can perform compared to the normal hearing group. So what is the best speech test for you? This is a very complicated question. It actually just depends on the access of the speech test that you have, because there are so many designs of speech tests with different purposes, using different types of materials, different administration approaches, many different scoring methods, and also definitely each speech test would have different norms lah. So for today, I'm just going to discuss two factors that could affect speech test results. One is the effect of signal type. One is that there are many signal types that you can use. You can either use nonsense syllables, you can use words in sentences, you can use whole sentences, or you can use digits as signal. Each type of signal type would yield different results. Typically, nonsense syllables would provide or give you a more flatter slope, meaning that their ability to differentiate between groups of different levels of hearing loss is not as good as compared to digits, as you can see here, with higher sloping, steeper sloping curve. In this way, you are most likely able to differentiate between, say, for example, a normal hearing person with a mild or moderate hearing loss person more accurately. Then I would like just to share you very briefly about the types of noise that are used in speech in noise testing. We can categorize them into two. One is energetic masking and one is informational masking. On your left here is the spectrum of an energetic masking noise, where the spectrum of the signal and the noise is exactly the same. Energetic masking refers to masking that occurs in the auditory periphery, and the aim of using this type of masker is to reduce the intelligibility by making the target stimuli inaudible, basically like what we are doing in masking in our PTA. We try to mask the pure tone signal using the same size auditory filter of the pure tone signal. So we want to block the speech sound as much as possible, and what is important here is the ability of the cochlea to try and draw out as much information as possible from between the speech and the noise. But informational masking is slightly different. When you use it refers to masking noise that interferes with speech reception at higher auditory levels, especially the cognitive processing. Typically, the types of noise that you see for informational masking is by using speech itself and compete or present the sound together with the signal, which is also speech. So the listener needs to really draw out information that is required, which is the signal, in basically babble sound or multiple speaker sound that is going on in the background. So this requires a top-down process and requires a lot of attention and increases cognitive load on the patient. And typically we use this type of noise to evaluate patients' performance using hearing aids. Okay, let's have a quick look at the application of speech tests in noise. Particularly, we have a lot of application of speech tests, but the slide that I'm showing you here is specifically for speech in noise tests. Obviously, we want to see whether we are able to measure how well listeners understand speech. Ultimately, our job as audiologists is to try and improve a person's communication abilities. We have a tendency to depend too much on pure tone results to try and derive how a person can understand speech, which is not necessarily the best approach to do this. So we do need to have speech tests. And a speech test in noise is particularly useful because it reflects, it's a better reflection of the real world speech ability, speech perception ability, sorry. The next application is to reflect the degree of communication handicap caused by hearing loss. As you can recall earlier, we spoke about the SNR loss category to see how much the person is handicapped or disabled by their hearing loss and how much sound increment or signal increment that is necessary for the person to be able to hear better. Speech in noise test is very important in the planning and management of auditory habilitation and rehabilitation. We're talking about hearing aids and cochlear implants, and see whether the management of hearing aids is efficient enough, whether you have given the right setting for the hearing aids to address noise and also to improve speech perception. So you do need these tools to be able to get the information, because at the moment right now, I think we're just doing a lot of guessing work by manipulating the hearing aid based mainly on the patient's report. Oh, I can't hear this thing well, so I'll just change the gain here and there. So this is a bit problematic, because most of the thing that we are doing is just guessing. And most of the time, when we start to fiddle with the amplification too much, we have the tendency to go far away from the right path now, and then we have to just reset and start again. So having a speech test as a baseline to see how well the patient performs in the beginning, and then start to try and improve how the electroacoustics of the hearing aids or the cochlear implants and see how much you can extract the function of the hearing aids and CI for the patient to improve the signal to noise ratio listening of that patient. Speech test is very important for selection criteria for cochlear implants. Unfortunately, I think we are lacking behind in this matter. Most countries would depend on how a person progresses with aided speech test results before deciding on when or how or when to use cochlear implants. Unfortunately, again, we are dependent too much on subjective reports and questionnaires to arrive to a conclusion when it comes to selecting people for cochlear implants. One specific application of speech in noise test is remote testing for hearing aids and cochlear implant. So the amazing thing here with speech in noise test is that you are going to present the signal with some noise in the background. So as long as the noise is louder than the ambient noise in the room, then this makes it possible for you to have to be able to record speech performance reliably outside of your clinics. And this has been the trend for especially cochlear implant testing, where tests like the digit in noise or digit triplet tests are used to evaluate speech performance remotely on patients with cochlear implants. I suppose we are not there yet, but hopefully this can be applied to our patients. It's quite simple. You do not have to necessarily have specific equipments, because most of the time the tests are designed to be robust, to be used in different listening environments, and does not require a sound treated room for you to test, to use the test. And most recently, we found that speech in noise test is a valuable tool to predict school performance in primary school children. So there was recently a paper published from the team from the University of Melbourne, and they have found that there's a significant link between speech in noise performance and reading abilities in school children. They suggest that there is an interrelated process that occurs at the cognitive level between the processor. There is a huge link between the processes of listening in speech in noise and also reading abilities. It is a very new study and quite revealing. We're glad to, and this information is quite crucial, I think, in terms of how we are going to position ourselves as audiologists in the education system. Because at the moment, our role is a bit small. If we can establish a good system to test children across the board in schools, and could help identify students who are struggling in their studies, then this would open up more opportunities for audiologists in Malaysia. All right, almost there, folks. I would like to introduce you some of the speech tests at IIUM so that you can contact us and then try and get access to the speech test. First of all, let me introduce you to some of you. Maybe many of you know already the Bisyllabic Malay Speech Audiometry Word List, or BMSA. The author of this test is Dr. Marina Anissa Putri. It is a bisyllabic Malay words test using a consonant vowel format in each word. The test has very good correlation with PTA, and it's a test done in quiet. It has 15 lists with 10 words, and there are 2 lists which include meaningful words and nonsense words. The test is scored via phoneme, and the scores and the marks are recorded in a performance intensity function graph. So it's very simple. If the stimulus is PADI and the response is PADI, you score it with a score of 4. If it's PADU, then you score 3. If it's AGA, then only one sound is correct here, which is R, so you score 1. And if the answer is KEJU, then you score the patient 0. And you accumulate the score within the list, and then you get the percentage over the overall word list. And this will be done at different intensities for you to be able to mark the performance intensity function. This test is very good for you to compare with your PTA results, to look for consistencies between your PTA results, as well as to use it for differential diagnosis for retrocochlear pathology, if you suspect patients who are malingering. So this is an excellent test for you to do that, as well as, of course, all of the applications that we mentioned earlier for patients with hearing aids and cochlear implants and all those things. Next test I would like to share with you is the Malay digit triplet test. This test was designed way back in 2004. It is the official screening test that is used by WHO at the moment, and there are many versions in many languages available at the moment, and hundreds of thousands of people have benefited using this speech test. And this is how the Malay speech test sounds like. So the audiologist does not need to do anything. The test runs by itself in a specific software, designed by a colleague in New Zealand. The test uses a simple 1 up and 1 down adaptive procedure. So whenever you score correctly, it will go 2 dB lower, and then keeps on continue with the test until you've completed 27 triplets, and it will automatically calculate the signal speech recognition threshold in noise for you. So we've also done this test on patients who are, because one of the concerns here, Malaysia being a multiracial country, we are concerned whether non-native Malay speakers are able to form similarly or not. I'm happy to report that native and non-native speaker, we found no significant difference between native and non-native speakers when using the digit triplet test. As I mentioned earlier, the test is robust against robust in terms of interference from from external factors. We've done this test at different rooms, calibrated rooms, non-calibrated rooms, with different headphones, with different sound cards, and we found that the results are still consistent despite being tested in different listening variations. And this is the reference value for the normal groups for the digit triplet test. Then we have the Malay metric sentence test, which is designed to be a diagnostic test. It uses sentence materials. It can be presented in quiet and also in noise. It uses a very unique adaptive signal level or signal to noise ratio. It can be tested auditory alone, but you can also test it visual alone or auditory visual modality mode. You can test this in a closed set or open set response format, so it's quite flexible. because of the nature of the test, there's a possibility of unlimited repetitions of measurements because of the design of the test you will see later. So, and the test is also ready in terms of the different types of background noise, both energetic and informational masking noise. So it uses an adaptive step method. I don't want to bore you with the technicalities, but basically it will automatically track the performance of the patient and changes how much the intensity, the intensity changes automatically depends on how well you respond to the test. And this is how it sounds like. So the patient just needs to click the screen or using a mouse, or if you want to do it as an open set test, the patient needs to listen to the sounds and then just repeat after each word that the patient can hear. So we've evaluated the test on patients with varying hearing levels and found very consistent, significant and consistent results for both tests in both types of noise. And again, we've performed the test on non-native speakers, and we found that the performance of the non-native speaker and native speaker seems to be similar. There's no significant difference, but there's a caveat here. All of our participants in this study had formal education up to SPM level. And this is the reference value in noise, and I'm happy to report that we've already completed our normative study for the test in quiet as well. So you can do the test in both quiet and noise. Also, one of the limitations of this test is that due to the complexity of the test, it uses 5 words per sentence. There's a learning curve that the patient needs to go through. So therefore, the recommendation is to ask the patient to listen to one whole list, practice with one list, and then discard that list and then start testing afterwards. So the speech recognition threshold data would only be valid after you've completed one practice list. Because of this complication, we did another study to try and simplify the Malay matrix sentence test from 5 words per sentence to 3 words per sentence, or not even a sentence. It's called a pseudo sentence. It's just number, object, and adjective. And alhamdulillah, we have completed the normative study done by my colleague Dr. Azhar, and we found that the results are quite consistent, where all 9 test lists showed homogeneous and equivalent intelligibility in both types of noise, both energetic and informational masking. We've also tested the simplified Malay matrix test because we want to see whether you can actually use this test in children or not. And we found reliable results from patients as young as 6 years old. However, due to developmental differences, then we have different norms for different age groups. So audiologists who like to use this would have to be mindful of the norms, different norms for different age groups in children. So the test can be done on children as well as adults, and more studies will be done for older adults coming soon. How do you set up the speech test? The BMSA is licensed under Interacoustics. I'll just say it outright. So if you want access to the BMSA, the speech test in quiet, then you have to contact Dr. Marina and the people at Interacoustics. However, for the auditory visual Malay matrix sentence test, the digit triplet test, and the simplified matrix sentence test, what you need is that you need a PC. You need a PC to download the software. You need an audiometer to connect the PC to the audiometer through a 3mm cable, both male to male, so that you can plug it into the external input of the audiometer, and the output goes out to your respective transducers lah, your AC and your free field speaker. There's a short calibration process that needs to be done using a calibration tone. As soon as we've done that, then your system should be calibrated already. But as I mentioned earlier, the test is more flexible because you're testing in noise and not in quiet, so you don't have to be too concerned about absolute testing absolute sound pressure levels. And when the noise and the signal comes out from the same transducer, what we're more concerned is the calibration of the SNR. So as long as the SNR can be maintained, then the results will still be reliable. So you do not need to have an audiometer for the speech test. If you want to have a standalone system, you just need a PC. You need an external sound card to ensure that the sound quality and the intensity of the sound can be made loud enough. And then, of course, you have to plug your external sound card to any types of reliable transducer, headphones, and also any reference speaker that you can find. Right. As a summary, in Malaysia, we do have validated speech in noise tests in Malay. Yesterday, two weeks ago, one of the ENT came to me and complained, say, why is his audiologist complaining that we don't have speech tests? Why they don't do speech tests? Because we don't have any speech tests in Malay. So maybe access is limited. Therefore, what I want to offer to everyone here is that at least for the Malay matrix sentence test and the Malay digit triplet test, I am happy to share this test for you for free. But I think you have to invite me to come and help you calibrate and ensure that the installation goes properly, because there's a few steps into installing the speech test into your PCs, and then there is a serial number that is linked to a server with National Instruments, which is the software that the test has been based on, and that needs to be used under my license. So I'm happy to share those tests with you. If you are keen, just contact me, and then hopefully we can come to an arrangement to come and visit you and then install the test for you. As I mentioned many times, we should adopt both speech test in quiet and in noise to enhance our services. We need to start to reduce our guessing game, and then hopefully we improve services, increase client satisfaction, and reduce the appointment numbers, because many audiologists have this misperception that having specialized tests would increase the number of appointments that they have to come up with. This is not necessarily true. I think there are a lot of publications on real ear measures, for example, to show that if you conduct all these things systematically, then the number of appointments can be reduced significantly, and most likely your patients will be satisfied. Thank you for your attention, everyone. This is my email. If you want to contact me, I'm happy to take your questions if you have any. Thank you very much for your attention.
Thank you, Dr. Saiful, for that excellent presentation and the reassurance that we really do have Malay word tests in Malaysia available. Okay, we do have a lot of questions actually.
A lot? Oh no.
Yes. Okay, so to start with, Wilson actually asked, would the administration of a speech in noise test be appropriate or effective for patients with severe to profound hearing loss?
Yeah, it's a very good question, Wilson. Thank you for that. Yeah, there are some limitations in terms of to whom can the speech test be tested on. For patients with severe to profound hearing losses, most likely the results are not going to be very nice, but it depends on the speech test as well. Some speech tests have very low ceiling and floor ceiling levels. for speech tests which uses adaptive test procedures like the Malay metric sentence test. It can still be used to some extent, but for those type of patients, I think the application is more useful when they are aided. So as soon as you've aided them, you CI, then see how much gain that they can get out of their devices afterwards. Yep.
So moving on to the next one. It is interesting that there is no correlation between speech in noise perception ability and positive effects. Could you elaborate more on this finding?
Thank you for that question. There are many studies to show that the subjective perception of satisfaction of devices are correlated to speech in noise tests actually. But in our study at IIUM, we didn't see that correlation, unfortunately. But most of the study agree that there is no correlation between the positive effects of using self-perceived positive effects of using device with speech in quiet testing. So they are a bit more correlated to speech in noise, but not so much with speech in quiet.
Okay, next one. Thank you, Dr. Saiful, for the interesting talk. Any of the speech tests that you used reached ceiling effect easily?
So for the Malay digit triplet test, it goes as high as 14 dB SNR. For the Malay metric sentence test, there's no limit. It will just keep on going, but the steps will be reduced to ensure that the hearing is protected. Any speech test ultimately will have a ceiling effect. It's just making sure that you know the test that you have. To a quick answer, yes, of course, there is a ceiling effect for any test.
Yes, correct. Very good. Next one. This one is an interesting question. I know speech in noise test is good, but how do I convince my boss that this test has good ROI? Return on investment.
Return on investment. Tell your boss that I'm giving it for free, so there's no charge.
100% investment returns.
100% investment.
Yes, and that would be a proof of concept actually. If you have those kind of tests and patients give good feedback, you will be able to justify the paid ones as well.
Yeah.
Okay, Salam, Dr. Saiful, could you describe a bit more how do we correlate the PTA and BMSA results?
Oh, okay. It's a full lecture actually. Anyway,
Yeah.
the speech recognition threshold for the BSA should correlate with the threshold, the average pure tone threshold for that patient by about plus minus 10 dB. That's a short answer. In terms of other things, when you test speech test in quiet, there is such thing called the maximum score or word recognition score, which is the maximum score that the patient can do when the intensity is increased. And this correlates to the level of hearing loss and the type of hearing loss as well. So there is a reference and a norm that you need to know.
So this actually brings back the needs for us to probably have like short courses where we have hands-on to do these tests.
Yeah. We have to, because these are tests that requires some skill to do actually. It's not just leaving your patients in front of the PC and press everything. You do need to have some understanding on how the test works.
Okay, so maybe we'll work on that too. Okay, next question. Are there normative data for open set in free field as closed set you have?
Yes.
Okay.
Short answer, yes, we have.
Yes, they have. Okay. Thank you, Dr. Saiful. Do you think you are able to provide the speech test for overseas audiology clinic? You have to travel.
Overseas.
Yeah.
Hmm.
Please contact Dr. Saiful directly. I think something can be arranged.
Do we have native Malay speakers overseas? I'm just concerned. Because
Singapore, Brunei.
okay, maybe yeah. As long as the users are native Malay speakers, it shouldn't be a problem. If they are non-native speakers, I believe from our study, you do need some formal education in Malay to be able to get this right. Otherwise, I suspect that the results will not be the same as compared to the norms.
Okay, so next one. Hi, doctor. I'm not sure whether there's specification for the external sound card that we should look for before buying, or any external sound card is okay.
There is a requirement. Those interested, I will share with you the specifications. There's a certain impedance level that we're looking for, and certain functions. What we're trying to do is trying to make sure that the sound produced is close to the reference value of the speaker and the headphones, which basically means that the flat frequency response. So I've tested with very cheap sound cards. They exploded, so might as well just use your own PC sound card. Is even better actually. So
Okay.
that's a short answer.
Right, two more questions to go. Thanks, Dr. Saiful. Looking forward to get the BM word list from you. Appreciate it. Just want to know, will it be compatible with any audiometer brands?
So far, we have no issues. I've installed a few in quite a few centers. So as long as you have an audio external input jack that you can connect your PC to the audiometer, then it should be good to go.
Okay, and Aline asks, thank you, Dr. Saiful. If you're given only one choice, would you go for RAM or speech audiometry test for retail HA setting?
Sorry, between RAM?
RAM and speech audiometry test for retail hearing aid center settings.
Well, these are two different things. I think
Apples and oranges.
yes, apples and oranges. I think you should have both. They serve different purposes. And I think these are the two main, it's good that you brought that up. These are the two main devices or tools that we are lacking behind, I think, in our services. So we should be looking forward to have both actually, not just either one.
Very good. Last one. Could you provide the paper for the Malay speech test that you mentioned that is easy to administer?
Which one? The Malay metric sentence test?
I
Yeah.
think the simplified MMST. Yeah.
Oh, the simplified one. The
Yeah.
simplified one, the thesis is out. Some of the basic development processes have been published, but the main paper is coming out soon. So I have to give you a disclaimer. The simplified Malay matrix sentence test will not be shared. This one will be commercialized. So as soon as we have gathered all of the necessary data to have this commercialized, then only this will be available. So I don't want to wait too long. I know everybody is looking forward to testing your patients, so that's why I'm sharing the digit triplet and also the normal Malay matrix sentence test first. But the simplified one will not be available for free lah. That one you have to buy later.
Oh, you use the free one, and if you can justify it to your boss, then you
Yeah,
can
it's a good
pay.
start, isn't it?
It is, it is. And I believe that is the way to go. We have to invest for tests, and that would justify our usage. Okay, we've passed the 9:30 mark, so apologies on that. But it has been an interesting talk. We attracted more participants than we expected. We actually hit our ceiling. We have 100 people in the Zoom platform, which is the record, and we've heard that some are not able to come in, so apologies on that. The next session, we will expand it to more participants. So thank you, Dr. Saiful, for sharing your knowledge, for sharing your tests. We truly appreciate your time. We truly appreciate your knowledge here, and we look forward to more sessions. For everyone else, thank you very much for joining us. This year is really special for August Audiologist. This is the first year that we are having a collaboration between MASH and MANSA. So a huge thank you to the two presidents, Techai and Dr. Sarah Rahmat, for supporting it, for putting the effort for us to be really successful this year. So hope to see you all in future sessions as well. Thank you very much. And with that, we end the session. Thank you.
Thank you.